I wanted to talk about weight loss surgery today, and we're going to give a little overview on what's available for patients nowadays. And this is an introductory kind of seminar to talk about obesity, the impacts of obesity on our patients, and different ways of treating that. So, today we're going to talk a little bit about my background as a bariatric surgeon, and we're going to dive into obesity, why it's such an important topic, why it affects so many millions of patients, and how to really treat and deal with obesity. Specifically, we're also going to touch a little bit about obesity surgery, what's available, the different surgery options that are out there, and we're going to lead in with a video that I think does a really good job of kind of explaining obesity.
Let me introduce you to Amanda. You're just meeting her for the first time, but chances are you're already making assumptions about how much she eats and how little she exercises because she's obese. But I'm about to show you that there's much more than meets the eye when it comes to obesity. There are lots of Amandas out there and they need treatment. Maybe you're one of them, or maybe you know an Amanda. It's time to act on obesity. But in order to do so effectively, we need to understand obesity. It's generally accepted that body weight is determined by a pretty simple formula. We call it the energy balance equation, and it works like this. If the number of calories that you consume equals the number of calories that you burn, your weight remains the same. If you consume more than you burn, you gain weight. And if you burn more than you consume, you lose weight. Most people think that those of us who properly manage our energy balance remain lean, whereas those of us, like Amanda, who eat too much and exercise too little, become obese. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This may sound logical, but it's wrong. Let me explain. First, let's talk about set point. No, I'm not talking about the point in a tennis match when one player is about to beat the other. I'm talking about a theory that says that no matter what you consciously want your weight to be, your brain has its own sense of how much body fat it should have on board, and it has a complex system in place that very precisely regulates your energy intake and expenditure to keep you within a so-called set point range for body fat. So that whole energy balance equation, it's not something that you control voluntarily. Your brain regulates your calories in to your calories out for you. For your brain to do this, it needs to know how much energy you have on board at all times, and it knows this by listening to hormones like leptin, which is made in your body fat. You can think of it like a car. Leptin is the gas gauge that tells your brain how much gas is in your tank, but leptin is just one piece of the puzzle. You've got a whole bunch of other hormonal signals and sensors that are involved too. Your bones, muscles, pancreas, liver, GI tract and sensory organs, they all play a role, communicating with your brain to give it the information it needs to do its job. But that's more detail than we need for this conversation. The point is that you have a complex system in place that regulates you to within a set point range for body fat. So what happens if Amanda decides to lose weight by going on a diet? After all, people with obesity should eat less, right? Here's what happens. She loses weight, but her hormone levels change. Her brain hears this, and it starts acting to restore whatever body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning fewer calories than before. You see, set point is usually a one-way street. Once it's been elevated, the brain works to defend it, just as vigorously as it would a lower set point. Amanda's brain doesn't know that she needs to lose weight. It only knows to defend her current set point. Back to our car analogy. Amanda can't help but look for a gas station to refuel when she sees that her gas gauge is low. At the same time, she becomes more fuel efficient, burning less energy than before. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda that she needs to be a more careful driver, when the real problem is that she needs a mechanic to fix her car. Okay, so if we've all got this complicated system in place that prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? How can we explain the obesity epidemic? Getting back to Amanda, why did she develop obesity? The answer is that it takes a perfect storm to cause an obesity epidemic like the one we're seeing now, and it's our modern environment that places us, and Amanda, directly in the path of that storm. While there's no single cause for the rising rate of obesity, changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that promote weight gain all play a role. Our unique genetics and developmental histories cause each of us to respond differently to these elements of the modern environment, and some of us, like Amanda, respond by sending hormonal signals that elevate our set point for body fat. It's not that Amanda's system has stopped working, it's just that it's working to regulate her to a set point that's too high. So you can think of obesity as a biological response to the modern environment, a disease where the body dysregulates to a body fat set point that is too high. Back to our car analogy. The size of Amanda's gas tank has expanded, so she carries around too much fuel. For Amanda to lose weight and keep it off, she needs to find a way to lower her set point. That is, rather than declaring war on her own biology, she needs to find a way to make her body regulate itself to a new, lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to be the most effective long-term treatment of obesity. But how bariatric surgery works is often misunderstood. Most people, even many doctors, think of bariatric surgery in terms of restriction or malabsorption. It's a reasonable assumption that surgery would work in these ways. After all, the procedures usually consist of some combination of altering stomach anatomy to be smaller, which you think would restrict the amount of food that you'd be able to eat, and rerouting the GI tract in a way that you'd think would make you fail to absorb the calories that you do eat. But new research suggests that certain types of bariatric surgery, for example, gastric bypass, sleeve gastrectomy, and duodenal switch, affect the signals between the brain and the body to decrease appetite, increase feelings of fullness, increase metabolism, and even encourage preferences for healthier food. Surgery may change the set point for body fat. It's like the anti-diet. Instead of fighting the set point like a diet does, surgery may recalibrate it, and the hormones that stimulate weight gain when a person diets do the exact opposite after surgery as the body regulates itself to the new lower set point. So here are 3 things you can take away from all of this. 1. Energy balance is complex and highly regulated. 2. Obesity is a disease where the complex system that regulates body fat may dysregulate to a set point that is too high. 3. Bariatric surgery may work by changing the signals that regulate body fat set point, enabling patients to successfully lose weight and keep it off. It's time to reshape the conversation about obesity. It's time to look past diet and exercise as the only treatment solution. It's time to act on obesity. And now that you've been educated, here's a simple way for you to act. Share this video. Let me introduce you to Amanda.
Here's one of our success stories I kind of wanted to start this talk off with.
Basically all my life I was fighting with overweight for more than 16, 17 years. I did all the diets that you can imagine. I just didn't lose the weight. When I came here I was desperate. Dr. Rekkas is my hero. He saved my life. Manatee Weight Loss Center is a place where they care a lot about their patients. In 17 months I lost 135 pounds in Manatee Weight Loss Center. Thank you, Dr. Rekkas. Basically all my basic.
So, a little bit about me. I am actually raised in Anna Maria Island here in Bradenton, Florida. I started off locally here, went to Manatee High School, eventually went to University of Florida for my undergraduate degree, went to Florida State University for my medical degree, and down to the University of Miami to finalize my surgery training and a fellowship for minimally invasive and weight loss surgery. Currently, I'm the Director of Metabolic and Bariatric Surgery at Manatee Memorial Hospital. I'm the only surgeon in Manatee County with a bariatric fellowship, and the only surgeon in the county performing both sleeve gastrectomies and gastric bypass surgeries robotically. I want to start off by talking about obesity. And when you talk about obesity, it's such a complex topic, but there's a lot of things that have changed in obesity, I think, luckily. When we talk about obesity in the past, we used to think that obesity was just a failure or weakness of the person. Now we know that obesity is a disease, and we know that this disease causes serious health problems in our patients. We used to think that diet and exercise was the only way that we can help patients overcome weight. Now we know that surgery is the only proven method to effectively treat the disease long term. And again, we used to think that weight loss surgery was a very extreme or dangerous thing. Now we know that weight loss surgery is safe, it's effective, and for many patients, it's a wonderful tool. When you talk about obesity, obesity is the second leading preventable cause of death in this country, right under smoking. And the numbers that are affected by obesity are quite staggering. And we also know that it is preventable and it is treatable. So when we talk about obesity, we really have to think about it as being a chronic disease. There's well over 200 million Americans that are obese. We know that 67% of the population are either overweight or obese, and it's predicted by 2030 that over half the population will be morbidly obese. So again, what's the big problem here? Well, we know obesity increases heart issues, specifically high blood pressure, diabetes, um, and heart disease, stroke, heart attack. There's a huge list of things that are directly related to weight gain in our patients. So again, we think that things have changed dramatically, and over the past 20 years, the weight loss, the weight numbers of obesity, the sheer weight of the number of patients that are overweight has doubled. So something's gone wrong, something's happened. Over the last 20, 30 years, these trends have not been present before. So the question is, what's going on and why is this happening? So first, let's talk about what is morbid obesity. It's a term that's used a lot in healthcare. So when someone is morbidly obese, on average, we think that they are about 100 pounds above their ideal body weight. And in order to calculate someone's body weight, we use a term called BMI. That stands for Body Mass Index. And having a BMI above 40 classifies most patients as being morbidly obese, or having a BMI greater than 35 with medical issues such as diabetes, high blood pressure, sleep apnea, arthritis. And again, more than 30% of the US population meets this criteria. We have this horrible epidemic in America now, and it's a very challenging thing. We've seen how the sizes of our portions have increased over the past 30 years. Our ability to exercise and be active has decreased, so this has become a perfect storm. And if you look at things have changed, if you look at just food options, so in 1900, when the Hershey's bar came out, there was one size, 2 ounces, and that was about 300 calories. Currently, the Hershey's bar increased over 3 times to 7 ounces, and now that's 1,000 calories in that bar. Again, Coca-Cola used to be 6.5 ounces, one size only 80 calories. Now Coca-Cola is the normal size is 16 ounces or 194 calories. So as our sizes and portions have gone up, so have our caloric intake. Again, typical hamburger or cheeseburger in 1955 was only 2.8 ounces or 202 calories. Now you can go to a place called the Heart Attack Grill in Las Vegas and get a 24-ounce cheeseburger that's over 20,000 calories. So this shift in portion size increase and what we expect to eat at every table when we sit down has gone up dramatically, impacting our weight and our health. So this is a very important slide, and this slide talks specifically about the price of obesity. We know that patients that are overweight have higher risk of migraines, high cholesterol, fatty liver disease, metabolic syndrome, diabetes, polycystic ovarian disease, venous issues, gout, joint disease, stress, urinary incontinence, reflux, high blood pressure, heart attack, asthma, sleep apnea, depression, and something called pseudotumor cerebri. The amazing thing is when we decrease the weight of our patients, when they get healthy, these things for the most part either get cured or improved dramatically. But there's also another component that we need to talk about, and that's mental health in our obese patients. This affects their self-esteem. There's a social stigma that is associated with being overweight, and we know specifically there are higher rates of depression in obese patients, and in morbidly obese patients it is expected to have up to 90% depression rates. Okay, and that's 3 times greater than normal. Um, so the question is, we have this problem. It's a trend that's changed in society. We know it has an impact. Well, what can we do? And this is a complex part of obesity medicine. There's so many diets, there's so many pills, there's so many things out there that promise great results. Let's talk a little bit about them. So, when you talk about initial weight loss therapies, nutritional therapy, increasing physical activity, behavioral therapy, hypnosis, medications, combination of the above are all available. The question is, why don't all diets work? And that's a complex question that has a complex issue. When you talk about diets, the body initially responds to any change, and we really do believe now that most patients have a set point of their weight. So even though you may go on a diet, you might lose some pounds here and there, the body will eventually go back to that normal set point. So it takes a long time for every diet or for any activity program to really be successful. So there's also medications that change weight, but there's also hormones in your body that prevent that. So there's thyroid hormones that drop when you diet. There's a hormone called lipoprotein lipase that increases your fat storage when you try to diet. So when you binge eat, you get these feelings of happiness when you eat, but these diets don't address people that have issues with overeating. There's also a feeling of deprivation when you're on a diet, and it's just not sustainable long term for 95% of the people out there. So again, old theory, eat less, be more active, you're going to be fine and lose weight. Well, you know now that doesn't work because obesity is related to genetics, hormones, diet, activity, and exercise. So again, there's a whole cascade that leads our patients to obesity, and the brain increases hunger, and it also when you don't eat, um, your hunger goes up. So what we know that in surgery, when patients have surgery, this set point of set weight tends to decrease. So we find in patients that have weight loss surgery, their brain hormones change, and their stomach has a different way of communicating to the brain, and that means decreased hunger, okay, increased caloric use, and the weight comes off, and in a way that's sustainable long term. So let's look at different weight loss strategies. Commercial weight loss programs out there like Weight Watchers, Jenny Craig, on average, people lose about 2% of their extra weight. Medications like Ally, Xenical, 3%. Medications like Sumatriptan, Meridia, which was pulled off the market, 5% weight loss. The best thing our patients can do without surgery, on average, is a supervised medically weight loss program, but still only 7% weight loss compared to gastric balloon and lap band surgery, which have 40 to 50% weight loss. The most effective surgeries out there currently, um, with the best data, are the gastric bypass and sleeve gastrectomy surgeries, where we expect about 75% of extra weight gone. You know, this is a huge change in what we expect from these other strategies. So weight loss surgery is a whole specialty and topic on its own, and it's very important that when you find a program, you find a program that is experienced, that has accreditation, and preferably at a center of excellence. So weight loss surgery has gained worldwide acceptance as the only proven way to treat obesity long term. And there's three main options available now. The original surgery is a Roux-en-Y gastric bypass. The vertical sleeve gastrectomy is the most common surgery performed now, and there's also a procedure called an adjustable gastric band or lap band surgery. So when you talk about the lap band surgery, this is a surgery that has really fallen out of favor in the last several years. Only about 2 to 3% of surgeons still offer it. And the reason is this. This is a surgery that involves putting a balloon around the top of the stomach. A surgeon places this balloon, and the risks overall are very low, but the weight loss is also much less of what's expected. We think that there's probably a 50% removal rate at 10 years with these bands, and the weight loss is not very effective because it doesn't change the hormonal cascade in the body. So patients eat, they tend to get full and nauseous, and they can vomit if they overeat, but their sense of hunger doesn't change, and their sense of fulfillment when they eat doesn't improve. This is what the lap band system looks like. Um, Again, now the original surgery that started off the majority of weight loss programs in the country is something called the Roux-en-Y gastric bypass or bypass surgery. It's a great surgery, does work very well, but it does have a lot of changes. In this surgery, we have to go in and we basically Reroute patients' stomachs. We make their stomach very, very small, about the size of a golf ball, and move their intestines around. So now when people eat food, it goes down this little stomach and into this intestine here, but the old stomach is left behind and bypassed. So the pros, it has a long track record, it decreases patients' hunger, improves metabolism, significant improvements in diabetics, and improves metabolic syndrome. The cons, of course, are the possibility of having issues with the intestines that are manipulated, the development of marginal ulcerations, and a significant decrease in absorption of vitamins and minerals. And it does involve uh, changing the small intestines, and NSAIDs and smoking are significantly contraindicated. But maybe in patients that have a severe history of reflux or uncontrolled diabetes, may be a better option. Sleeve gastrectomy is a surgery that's the most commonly performed surgery now, been ongoing for about 23 years now. In this procedure, the stomach is removed. We remove about 3/4 of the stomach, but we do not mess with any of the intestines here. There's no bowel connections or anastomosis to be made. And again, it's a very effective um, treatment for type 2 diabetes. But in about 3% of people, we think can increase reflux. Overall, the surgical success rate with this surgery is very, very high, with a complication rate depending on our patients of about 1 to 2% compared to about a 5% risk with a bypass. So again, the way we do surgeries now are all done robotically. Specifically, when you talk about a robotic sleeve gastrectomy, instead of having big open cuts, we have small little incisions, and our patients tend to go home in just 24 hours. Um, Most of these incisions are about 8 millimeters in size, so instead of having big open procedures like we used to, there's minimal scarring, minimal pain, and the procedures on average can take less than an hour to perform, sometimes only 25 to 30 minutes. This is a patient that had a sleeve gastrectomy surgery. There's their incisions afterwards. So these surgeries are not these large surgical um, scars that we leave on our patients. I think doing surgery robotically has really changed how our patients' outcomes have been, specifically their pain and their scarring. So the question is, who qualifies and who does not qualify for surgery? So first off, a patient that does not qualify for surgery is someone that has severe heart disease, heart failure, um, severe history of coronary artery disease, severe lung disease, severe liver disease, or any uncontrolled mental health disorders such as schizophrenia, uncontrolled bipolar disorder, and bulimia. Anyone that comes into the program has to be assessed and optimized. And that generally overall someone that has poor health that's unable to tolerate surgery, and also someone that's not willing to make a change in their lifestyle. So this is what you can expect. It's a long process. It takes about 3 to 6 months to get to surgery. Most people leave the hospital in about 1 to 2 days, sometimes the same day, and most people return to work in about 7 to 10 days, depending on what kind of work you do, with no heavy lifting for about 4 weeks. Now again, results vary from patient to patient, and everyone comes in at a different starting point in their surgery journey, but our job is to make a customized plan for everyone. So again, the weight loss program starts off with an initial consultation with the surgeon, meeting with the dietitian, an endoscopy to evaluate the stomach by a gastroenterologist, blood work, psych evaluation, optimization, pre-op visit, pre-op class, liquid diet, and then finally surgery. So we have a wonderful team of surgeons, PAs, dietitians, and schedulers that are all here to help you. And we have multiple centers of excellence that we work very hard to obtain and maintain. And I think whenever someone's looking at a program to operate on, the questions are, how long have you been doing this program? How many surgeries do you perform, and what are your outcomes? And as part of the Center of Excellence status, we have to maintain all that data at a very high rate to keep them going. So the best part of what we do are our patients, and we have an amazing group of patients that we've operated on through the years, and this makes our lives very fulfilling to be able to take part in the surgeries that these patients have, and the results are absolutely life-changing. So I want to thank you for watching this video. If you do have any questions, if you're interested, feel free to reach out to our program, and we have a very big social media following that you can follow too if you look at hashtag drrekkas.com. We appreciate you, and thank you.